Welcome everyone to today's webinar, Understanding and Managing Urinary Symptoms and Ataxic Disorders. I'm Lori Sjogren, the Community Services Director, and I'll be assisting with today's webinar. Now, it's my pleasure to introduce our exceptionally accomplished expert speaker, Dr. Jalish Paniker. Dr. Paniker is Professor of Neurology and Neuroneurology at the University of College London and clinical lead of the Department of Uroneurology at the National Hospital for Neurology and Neurosurgery in London. Welcome, Dr. Paniker.
Thank you very much, Lori, for the introduction. And it's incredibly excited. I'm incredibly excited to be here. The first time actually speaking to the National Ataxia Foundation. So the next 45 minutes or so, I would like to sort of take you through the assessment and management of urinary symptoms in ataxia disorders. And there is time at the end for questions. So I haven't included a conflict of interest slide, but just to say that there's nothing that I can assure you would influence what I have to say. It's just about urinary problems and what we can do about it. And essentially, two questions we're going to be answering here. One is, why are there urinary problems in ataxia disorders, and what can be done about this? Just going through the list of people coming through, it was like a world tour. I thought it would be just a tour of the United States, but it turned out to be around the world. That's amazing. But I'll tell you about my patch, which is actually in central London. I work at UCL, as we heard from Laurie, and at this hospital called the National Hospital for Neurology and Neurosurgery, which is at Queen Square. Now, the red brick building is the hospital, and this building on the left, which probably doesn't look as elegant, is the Institute of Neurology, or the academic hub. And what's great about the place where I work is you have the clinical care being delivered to patients sitting next to the research, which means that there's a bi-directional translation that's happening in terms of clinical questions that go to the lab and get answered, and we get sort of research output that immediately gets transferred into clinical care. Now, a little bit about our department. So this is a department that's dedicated to um, neurogenic bladder, bowel, and sexual problems. So individuals who have neurological disease or suspected neurological disease would come to our service, where we assess their urinary, bowel, sexual symptoms and provide them management. We are not a surgical department, so you will not be hearing about any urological surgeries today, but we do provide sort of conservative first and second line treatment for management of the urinary symptoms. Now, why I've put up this picture is to actually is really to share with you the importance of multidisciplinary team working. So that's myself and a colleague here, Sarah Simon. We're neurologists. This is a urologist, Marion Paxad. We have a gastroenterologist and a gynecologist who aren't in the picture. In addition, we have a lovely nursing team, and we have a psychologist, and we have a team of scientists and a pelvic floor physiotherapist. And so the assessment of urinary symptoms involves multiple components, and it's not just taking a tablet and seeing how things work. And I hope I'm able to sort of convey that theme throughout these next few slides. Now, why we exist is because of the figures that you see in this slide, because bladder problems are really, really common following neurological disease. People sometimes say that I do a very niche bit of work, but actually, when 100% of your patients with MS or spinal cord injury have bladder problems, and more than 50% of patients with Parkinson's do, it isn't a niche problem, but it's actually everyone's problem. And you'll find these statistics. Sadly, there are none of the ataxia disorders are on this, because we really don't know the prevalence of urinary problems in many of the ataxia disorders. Now, what we do need to understand, however, is that these urinary problems aren't just an issue about wearing pads or about quality of life. I mean, those are really, really important. But there's also a considerable impact on how we deliver health services. And this is data from the United Kingdom. So HESA is a warehouse of data that we collect from hospitals about admissions across hospitals in England. And this is actually a graph that shows why people with multiple sclerosis were admitted as an unplanned admission. And you'll find that by far the most common and most important cause for an unplanned admission of multiple sclerosis was related to the urinary tract, specifically UTIs. And this is really, really expensive. And you can see that, and this data from across sort of CCGs in England, we found it was a staggering nearly £1 million a year was actually the amount that had to be spent for the management of these conditions. So really it has an immense impact on the way that care is delivered. Now, as a neurologist, I see bladder problems in terms of conditions that affect the brain, the spinal cord, and the wires that come out of the spinal cord that we call the peripheral nerve roots and the nerves. And why I see it that way is because depending on where the problem lies, the bladder problems can change. So if it's a brain disease, for example, Parkinson's or stroke, for example, what we see is that individuals have a condition called an overactive bladder. So essentially, their bladder is misbehaving, has a life of its own, and it's giving symptoms such as urgency and frequency, which I'll be coming to in a few moments. Whereas if it's a problem with the spinal cord, for example, it could be multiple sclerosis, or it could be transverse myelitis, it could be a tumor, it could be an injury. What we find is that people tell us about overactive bladder, but also they tell us about difficulties in trying to empty their bladder, which we call voiding difficulties. And essentially, it's because the muscles of the bladder fail to talk to one another in a proper way. Now, sometimes we will have problems that affect the base of the spine. So this is including the tip of the spinal cord, and that's relevant to multiple system atrophy. You'll be hearing about later on in this presentation. But also it could affect the nerve roots coming out of the spine. For example, if there's a disc prolapse, which presses on the nerves, there can be a condition called a cauda equina compression. Or it could be a peripheral nerve problem that happens, and it can occur in some conditions such as Friedreich's ataxia, for example. Then what happens is essentially the signals aren't getting relayed to the bladder, and essentially the bladder muscle stops working. So, as a physician, and I ask about urinary problems, I ask about problems with holding the urine, and this is what we collectively call as overactive bladder symptoms. So, individuals could tell us about problems with needing to rush to the toilet, and the medical term we use for that is urinary urgency. They tell us that they have to pee often in the day, and that they have to pee often in the night, what we call nocturia. And if they do experience urinary urge or urgency or unable to reach the toilet on time, they wet themselves, which we call as incontinence, and we call this as urinary urgency incontinence. Now, this is contrast to problems with passing urine, which are voiding difficulties. And so the symptoms are quite different. So it includes urinary hesitancy, where the person says that they are unable to start their stream. And then perhaps they are able to start the stream, but it's a start interrupted stream. They may have to sort of bear down or strain when they pee, or they feel a sensation as if their bladder is not empty despite having passed urine, what we call a sensation of incomplete bladder emptying. Or they may actually finish peeing and then after a few minutes have to go a second time, which we call a double void. Or perhaps the bladder is just unable to empty, and we call this as urinary retention. So as you can see, when your doctor asks you about urinary symptoms, you will be telling them about different permutations and combinations of these symptoms. But what we think about is it a problem with storage? So it's a problem with holding urine? Or is there a problem with voiding or a problem with passing urine? Because it tells us then about what is going on in the bladder, and we then try to relate that to the neurological condition. So we ask a few questions about the bladder. We then sort of collect a urine sample. We test the urine for an infection. And then we check to see if the bladder is emptying after urination. We may then ask you to ask a person to keep a diary. So essentially, they'd have two measuring jugs. One they use to measure what they drink, and they measure those volumes, and they record at what times that they drink. So it tells us about their fluid intake. Now, when we have a diary that's then handed back to us, it's also then an opportunity to ask about what they're drinking, because the type of beverage they have matters. Now, with the other measuring jug, we ask them to measure what they pee in terms of volumes and when they pee, and it tells us about their daytime and their nighttime frequency, and also tells us about the volumes that they're producing in the day and the night. There are some conditions in neurology where actually the individual starts producing much more urine in the night than in the day. And this is actually not a bladder problem, it's actually a more medical condition. And there's essentially a shift of fluid coming out from the day to the nighttime, and we call this as nocturnal polyuria. Now, sometimes patients may undergo more invasive tests that we call urodynamics testing. And then, of course, we have a discussion about different treatments because it is one of the symptoms that an individual with neurological disease has that we can treat and sometimes even cure. Now, sometimes we come across individuals who say that I was managing reasonably well, but recently I've actually become incontinent. So in neurology, we have a few conditions that occur suddenly, for example, stroke, for example, or disc prolapse. But in most of the ataxias, particularly the ones that involve a thinning out of the cerebellum or the spinal cord, such as Friedreich's, for example, or SCAs or multiple system atrophy, things don't happen overnight. So if there is a recent onset incontinence, it gets us thinking it may not be the primary neurology, but it could be something urological. Maybe the patient has a urinary infection. And when we think of a UTI, we think about, oh, the burning sensation, the pain that is associated with that. We think about the smell, the odor, and we think about the change in the color. But sometimes urinary infections may lack any of these. It might be just something very subtle, like a change in bladder symptoms. It could be a change in medications. For example, someone who starts an opioid for pain relief that can cause urinary retention. There's a group of drugs called cholinesterase inhibitors that individuals with Alzheimer's use, and this can sometimes cause incontinence. Or there could be a recent restriction of mobility, for example, a fall or hip surgery, and they're not able to reach the toilet on time. Or perhaps there's what we call stool impaction, where they're not able to empty their rectum, they're constipated, can't get the stool out, and this has a bearing on getting the content of the bladder out as well. Now, I would like to highlight that when we talk about the bladder, it's very much a holistic approach because we can't just focus on the neurological problem. And then I suppose the converse is if you're a general urologist, you need to think about not only the general urological problems, but also the neurological problems. So you have the two ends, but we have to think about them actually all and line them up because an individual with MSA or an individual with Friedreich's may have an enlarged prostate, which can cause bladder problems. They might have their ankles might swell, and all that fluid that collects towards the end of the day gets reabsorbed in the night, and it has to come out to the bladder and contribute to a nighttime frequency or nocturia, or even increase volumes at night that we call nocturnal polyuria. They might be having other medical conditions such as diabetes or heart failure, which themselves independently can cause bladder problems, particularly nocturia. Or they might be on medications that can itself cause an increased urine output. And one such example are your water tablets that you take called diuretics. Essentially, they prune you out and help with reducing the ankle swelling, help if you have heart failure. But what happens is that there's going to be an increased pressure on the kidneys to excrete the fluid out, thereby more fluid to the bladder. And if the bladder is already compromised because of being an overactive bladder, this can then trigger, they can actually exacerbate or make the bladder symptoms worse. They might be having a totally unrelated condition. Many of you will be aware of this condition called sleep apnea. So essentially, it's essentially something like the person might snore, but it's really snoring on steroids, because essentially it's snoring. But what happens is that the upper the airways they collapse and the person is unable to breathe, and so momentarily quite frightening to see is that the person stops breathing, and then within a few seconds everything kicks in and they're able to start breathing again, and it's called obstructive sleep apnea. But what we know is in this condition it's related to producing more urine in the night that we call nocturnal polyuria. And though this isn't directly related to neurological disease, obstructive sleep apnea and neurological diseases overlap. and quite a few of our patients do have sleep apnea syndrome. Or they might be having other neurological conditions in addition to the ataxia, such as maybe a small vessel disease in their brain, or maybe cervical spondylosis, or wear and tear changes in their spine and their neck, resulting in spinal cord problems. So one of the key questions we need to that we ask when we assess someone with urinary problems is how much urine is left behind in the bladder. And this is called the post-void residual volume. And it can most elegantly be done by an ultrasound. And this is a handheld scanner. You can see that you can carry it around to the wards. You can carry it from one treatment room to the other, as opposed to your proper ultrasound machine, which you can't move around as quickly. Less ideal would be an in-out catheterization where a catheter goes in and the urine comes out and you measure it. And because of course the risk of an infection when you introduce a catheter. So in ataxic disorders, so what I would say is in the absence of any prevalence figures is that from our experience, and I would say that multiple system atrophy, I would say probably everyone has urinary problems at some point in the journey. With Friedreich's ataxia and spinocerebellar ataxia, part of our research has been to actually answer those questions. And one condition that we don't really know is this condition of LOCA, or late onset cerebellar ataxia, which I don't think, and there are very few studies that really have answered that question: how prevalent is urinary problems? So my links with the or interest in ataxia actually stems with a collaboration that I have with this professor at UCL called Paolo Ginti. So those of you from the UK will probably know of Paolo Ginti, and is a neurologist with interest in ataxia. Now, sadly, myself or my colleague Sarah Simeon are not in this picture, but we do collaborate really well with the Ataxia Center at UCL. We actually, Dr. Simeone, my colleague, actually runs a dedicated ataxia clinic. So this is ataxia and bladder problems. And we both work closely with Paola. We meet very often. And it's a very multidisciplinary approach to the ataxia disorders that we offer at UCL. And we're delighted to collaborate, and we provide sort of the advice about urinary, sexual, and bowel problems that individuals with ataxia disorders present with. So I'll start with a case vignette. A 57-year-old lady who presents with frequency nocturia and urgency for 6 years, has some hesitancy, so difficulties initiating their pee for 4 years, has recurrent urinary infections, is performing intermittent catheterization for the last 3 years. So that means they're now retaining urine. They also have been experiencing some problems with blood pressure control, have been reporting some poor balance for 3 years. So do note that that started around 3 years after their urinary problems. And with the presentation now, you'll see that it's all consistent with multiple system atrophy. However, when they first presented to us, sort of 4 years ago, for example, or 3 years, they didn't have neurological symptoms. And this is actually a presentation we come across where they first present with urinary problems. So what happens in multiple system atrophy is that it's a journey for the patient. And initially what we find is that the common symptoms are those of the storage problems that you heard about earlier. Urgency, frequency, nighttime frequency, we call nocturia, and incontinence. And there are different mechanisms that contribute to that. Now, what happens, and this results from different parts of the neurological system in the brain stem, and the spinal cord to be involved, which results in these bladder problems. Now, as the journey progresses, what we find is that from storage problems, the individual starts to develop voiding problems. And this is quite unique to MSA. We don't actually see this sort of gradual progression in most of the other neurological conditions, let alone the ataxia disorders, where generally the storage and voiding problems generally we start seeing early on together. But they start reporting problems with hesitancy, a poor stream, incomplete bladder emptying, urinary retention. Sometimes the individual reports none of these because the transition, not the transition, the development of voiding problems is so gradual that because a person doesn't go into acute retention, they may not appreciate that they are actually are having problems with peeing. And this only becomes evident when you go to a public toilet and you hear someone else peeing in the next cubicle, and then you realize that actually my pee isn't as strong as the person next to me. I wonder what's going on. Otherwise, if we pee in our private, toilets, we may not realize that they're avoiding problems. But as a physician, I always ask about two things. One is about recurrent urinary infections, and we know that stagnant water is a breeding ground for bugs, and often we find that this is a harbinger for urinary retention. And when a patient tells us about recurrent UTIs, we get them back for a bladder scan, and we often find that they are beginning to retain urine. The other symptom I ask about is there bedwetting happening in their sleep? So children bedwet in their sleep. We call this as nocturnal enuresis. But when we reach a certain age, we become dry. Now, in following neurological disorders, bedwetting can occur again. Now, when it occurs in this context, it's usually because they are retaining urine in the bladder. So if I hear these two bits from the history, for me, alarm bells are ringing, and I suspect that that person may now be retaining urine in the bladder. And what we find in MSA is that actually the degree of urinary retention worsens. And this is a very complicated graph, but just to show that as the number of years of MSA progresses, we find that the degree of the post-word residual volume, or the degree of urinary retention, actually becomes worse. Now, sometimes we come across people with MSA who have absolutely no neurological problems. They have only urological problems. And what we've come across from our research at UCL is that there's actually a group of individuals with MSA who present first just with urinary retention, and that's it. And they can actually present with retention, thereby they never turn up to a neurology clinic, but they're actually in a urology clinic. And of course, the urologist would be thinking about an enlarged prostate. A gynecologist may think of a prolapse. Many times you'll find that the prostate is operated upon, the patient doesn't get better, and later on they develop neurological symptoms. Now, what we've realized in our research is that actually the problem occurs at the end of the spinal cord, because this is a region of the spinal cord that's particularly important in bladder control, because all the wires that are heading to the bladder, the bowel, the sexual organs, and the pelvis actually emanate from this region. What we also know is that in conditions such as MSA, is that the same region is particularly vulnerable to the damage. And so in these individuals, what we think is happening is that this lower end of the spinal cord is damaged. Now, how we know that is that the patients undergo a test called urodynamics, and we find that their bladder muscles just cease to work altogether. And we perform a test called an EMG, which involves introducing a thin needle into muscles that are supplied by the wires that are coming out from the end of the spinal cord. So the one that's most easily accessible is the muscle around the back passage that we call the anal sphincter. And what we find is the anal sphincter EMG is often abnormal. So in individuals in whom we can't really diagnose something neurologically, if we perform these tests, we then know there's something neurological happening. Now, of course, at this point in time, the patient doesn't meet the criteria for MSA, but what we do suspect strongly is something neurological, and we closely monitor the patient and find that, that sadly that they do develop MSA over time. Friedreich's ataxia. So we performed a study, an observational study with the Ataxia Center, actually evaluating urinary, bowel, and sexual symptoms in a cohort of patients with Friedreich's ataxia. And what we did is it was very simple. We just sent out standardized questionnaires inquiring about these symptoms, and we got as many patients to our department as possible. To really assess their bladders. And what we found was that a staggering 80% of individuals with Friedreich's ataxia actually were reporting urinary symptoms. And for me, this was actually a total surprise, because when I started my work in neurology, I would never see a patient with Friedreich's in my clinic. I would never see a patient with spinocerebellar ataxia in a clinic. And so this came as a surprise, I think to Paolo Genti as well. What we found in our research is that these urinary problems are related to the duration of disease and severity. Now, we used the standardized questionnaire for bowels and found that more than half of the patients also reported bowel problems. But what we found was it was mostly minor. But also a staggering 80% were reporting problems with sexual performance and intimacy as well. Now, when we dived into the urinary problems, and what we found in our questionnaire is that symptoms of frequency and urgency and incontinence were by far the commonest urinary symptoms they were reporting. So for us, that's actually for as a physician, that's heartening to hear because actually we can treat these symptoms and make individuals better. We ran another study, and this time was another cohort of patients with spinocerebellar ataxia, and somewhat similar protocol. But what we found was here also was a very, very high prevalence of urinary symptoms. So when we just asked the patients, do you have urinary problems? 60% reported yes. But then when we gave the questionnaires, the individuals said that actually the figure went up to nearly 90%. Once again, what we found was that these symptoms of an overactive bladder, urgency, frequency, incontinence were commonest. What we found was that it was generally milder, and though we didn't compare head to head the SCA and the Friedreich's groups, when we look back at our results from the Friedreich's, we found that symptoms were generally milder. But actually, though they were mild, in nearly 80% of individuals, we found that it was impacting their quality of life in one way or the other. And in this group, in whom there was an impact on quality of life, more than half of them were not on any treatment at all for their bladder symptoms that were impacting their quality of life. Now, I'm putting up one of the tables from this paper just to show the distribution of bladder problems across a few of the commonest spinocerebellar ataxias that we saw. And though the number of patients were quite small, it's very difficult to derive any conclusions. But it is interesting to find that the duration of bladder symptoms varied. And so people with SCA1 and SCA3 had a very short symptoms, whereas those with SCA2, 6, and 7 had a very long duration of symptoms. And what we found, however, was that particularly with SCA7 was that actually their scores were much more severe. So they probably had a shorter duration, but more severe bladder problems, in contrast to, say, SCA2 and SCA6, where the long duration but less severe bladder problems over there. The third group of ataxia patients that we've been investigating is Xeroderma pigmentosa. Now, the reason why we thought is that I was maybe 4 years ago, I saw someone with XP for the first time. And it was so different and so unexpected that they were having a catheter. And I asked the individual, I asked him, why were you a catheter? And he said, well, I couldn't pee. So it got us thinking, why is it that a person with XP can't pee? And of course, we don't have the answer. But what we then did is we went back and looked at the individuals with xeroderma pigmentosa. And actually, it wasn't just that person, but everyone had problems with peeing. And the post-word residue volumes, which are generally going to be less than 100 ml, were quite high. And so by the time most of the individuals come to us, they're already in retention for some reason or the other. In contrast to your spinocerebellar ataxia, where we rarely see someone going into retention. And this is in contrast to Friedreich's ataxia, where we find that most people don't require catheters, but particularly the ones with SCA3 or Makata-Joseph, they, for some reason, have a predilection for developing urinary retention. And this is in contrast to multiple system atrophy, where initially individuals don't go into retention, but we find that as the disease advances, that most patients will need a catheter because of retention. So we now move on to what do we do about these symptoms. And so this is a simple algorithm I'm sure that you've never come across, but if you go through it, you'll find that it's actually not very easy, not very difficult to follow. Well, we start with those symptoms of urgency frequency that you heard about earlier. We test the urine for a urinary infection, once again, because a urinary infection can mimic symptoms of an overactive bladder, and whereas a UTI is curable, an overactive bladder is treatable. And we then measure the post-void residue volume by a bladder scanner or catheterization. And if we find that it's a low value, so that means we're emptying the bladder well, we then start them on medications. Whereas if we find that they are retaining urine, we check this figure to make sure it's right, and then we initiate them on some sort of catheterization. So we always start with conservative measures, and always it's a discussion that we start about what fluid. So what goes in comes out. That's the logic that underpins this. And this is where a bladder diary is particularly helpful because we then can actually have a bespoke, individualized approach to bladder management. Now, the general recommendation is to have around 6 to 8 glasses of fluids a day. But we know that certain beverages can irritate the bladder and can exacerbate overactive bladder symptoms. Many of you will actually, in your day-to-day life, even if you don't have an overactive bladder, can relate to drinks such as caffeinated beverages, chocolates, alcohol, anything citrusy, such as a lemonade or orange juice or your squashes, anything fizzy, such as your Cokes or your sparkling drinks, sparkling water. These can irritate the bladder in some way, or they cause a diuretic effect, and there's an increase in the volume of that's contained in the bladder. And so our first port of call, therefore, is actually to then negotiate what is feasible in terms of having a fluid intake that we would sort of aspire for, because it may not be practical to cut out coffee. There are only a few good things in life, I think, when you realize it. And some of this might be these beverages you see here. And so we don't want to be dogmatic and say you can't have it. But what we want to do is make individuals aware that look, if you're about to go out, to the cinema, you don't want to be having 3 cups of a sparkling drink because you're not going to enjoy your time in the cinema. And it's things like that that we introduce into our practical management. For some individuals, particularly with mild overactive bladder symptoms, we help with retraining the bladder. So we try, because what happens is if you become incontinent once, you never want that to happen again. So what you do is you map your toilets, but also you will sort of time your peeing so that whenever there's an opportunity you'll pee, even if you don't really need to. And part of it is actually unpicking this and finding how many of these voids are actually really necessary and how many of them are just in case pees. And that's sort of bladder retraining. And part of that also is bladder scheduling, so that you try to have you try to fix you try to schedule the bladder emptying or the pees. And this is some of the great work that our nursing team gets involved with. Pelvic floor muscle training, something that's often forgotten. You will be lucky if you've ever seen a pelvic floor physiotherapist. They're a very rare breed. And in the NHS, we have very few. And the few who are available for women who've had a nasty delivery. So men hardly get to see a pelvic floor physio. Now, we are lucky to have someone called Natalia Vasquez, who is a pelvic floor muscle trainee, a pelvic floor physiotherapist who is dedicated to seeing neurological patients. Now, when the pandemic hit, we realized that we couldn't get patients for pelvic floor muscle training, and we applied for some funding to actually develop self-help videos. So if you scan that QR code, it'll take you to the YouTube channel of our hospital trust. That's University College London Hospitals, and you will be able to access all these videos free of cost. And these are a way to initiate conservative management. As you can see, many of them are generic videos that actually even individuals without neurological disorders will benefit from. But these are sort of geared for individuals with neurological conditions, which includes your ataxia disorders, which actually helps because when we do then see the patient face to face, or when the nursing team sees them, the patient's sort of already aware of some of the things that are going to be discussed. Now, when we institute medical management, there are different tablets. So some of you who have bladder problems may be familiar with medications. These include oxybutynin. Now, if any of you are on oxybutynin, please tell your doctor to change it because you shouldn't be on oxybutynin. I'll explain why during the Q&A if time permits. Another drug that also has lots of side effects is tolterodine. So we ideally would like to put patients on one of the newer antimuscarinic agents, and this is really because they're far more selective for the muscarinic protein in the bladder. So they have a much more specific effect on the bladder, and thereby they have less of the side effects on the brain, on and other regions. And the newer drugs include drugs like solifenacin, darafenacin, trospium chloride. Um, and so, what these medications do is that they calm the overactive bladder. So they reduce the urgency, reduce the frequency, reduce the nighttime frequency, and thereby allow for better bladder control and thereby less episodes of urgency incontinence. There are clinical trials which have been really designed well, we call randomized control trials, that have demonstrated that these antimuscarinic agents work, and not specifically in ataxia disorders, but in conditions such as MS and spinal cord injuries, and that the side effects are tolerable. And the side effects are they include things like a dry mouth, dry eyes, constipation. Sometimes they can cause blurred vision. These are the common ones. Now, of late, there has been some concerns about using these medications, particularly because of their effects on memory. So some of you may be familiar. In around 10 years ago, there was a large study that was published from North America that showed that individuals who take medications that have a property like this, an antimuscarinic property, that the prevalence of dementia was greater. So these include pills for the bladder, such as antimuscarinics. These include some common medications used for depression called amitriptyline and tricyclic antidepressants, and also individuals who took medications for like antihistamines for a long period of time. Now, these were large population-based studies, so we really didn't know who these patients were. It was just looking at the records of pharmacies from across North America. So some of them would never have had a neurological disorder. Some of them would have had developed a bladder problem first and then developed their neurological problem, including dementia. So it could have been that they started the tablet for their bladder symptoms, but then already were on the course of developing the neurological problems, if that makes sense. We call that as a protopathic bias. So because of this, it was very, very difficult to derive any conclusions. But of course, patients will come in every day in clinic and ask me about this because it's very much in the lay press. And so what we know from experience is that it's extremely, extremely rare for someone to develop dementia following these medications, right? And so what we do is we have a conversation with the patient and the carer and say that, look, there is this risk, but then if you have a bladder problem that's keeping you awake all night long, or if you're wet in your pads, and you will develop problems with that. You will develop behavioral and cognitive problems just because you have a poor night's sleep, for example. Or because of the bladder problem and you're isolated in your home and you don't want to go out, social isolation will cause is a risk factor for dementia. And so it's really balancing it and put it all in perspective. And so this is why we would avoid medications that are not selective, like oxybutynin and tolterodine, and we would use the more selective drugs, which are less likely to cause memory problems, such as trospium chloride or this one called darafenacin. Um, but I'm sure this will come up during the Q&A session, and I'm happy to explain it again there. Now, there is an entirely different group of medications, so it's entirely different from what you just heard, and this is called mirabegron. And in the United States, and I believe in Canada, and more recently in the United Kingdom, you have another drug called vibegron that's available as well. Now, these work through an entirely different protein called the beta-3 receptor. And they also help with urgency frequency. And there are randomized control trials, particularly in Parkinson's, that have shown safety and efficacy as well. Now, these medications also help with reducing urgency and frequency and leakage. What we know is that their side effect profile is entirely different. So most individuals do tolerate this medication well, but the side effects are more around the cardiovascular system. So some individuals may experience palpitations. They might feel their heart racing, and so that's something we warn patients. Particularly relevant to ataxia disorders is that in the clinical trials, there were some reports, very uncommon, but some reports of individuals developing an arrhythmia called atrial fibrillation. So this is what particularly with the person with ataxia, what we're particularly we will particularly take care of before we start this medication is we look at their cardiology notes. So if the person is already having atrial fibrillation and it's rate controlled, they're getting good care essentially, it's fine. You can start the Baron. But sorry about this. If they have what's called paroxysmal atrial fibrillation, where they have AF for a while and then it reverts to normal, and then atrial fibrillation again, that's the sort of patient you want to avoid because you don't want to then give a medication that can then trigger off an atrial fibrillation, if that makes sense. Now, the third side effect, which is probably the one I first said first, I should have said first, is that extremely uncommonly is that the blood pressure may go up. And so we do recommend GPs to monitor the blood pressure, particularly soon after starting the mirabegron. And if the blood pressure is more than 180 by 110, in the United Kingdom, we're not allowed to give this medication. We move on to another treatment called tibial nerve stimulation. This is something you may or may not hear about, depending on which part of the country you're from. But it's been shown and it's been known since antiquity, since from traditional Chinese medicine, that if you stick acupuncture needles into the region behind your ankle, it's called the SP7 on the meridian, this is called the spleen line, that it helps with bladder problems. Now, it's been known thousands of years since that actually it's by stimulating the tibial nerve, which is a nerve that sits behind your ankle, that if you electrically stimulate this, it can help with symptoms of urgency, frequency, and leakage. So when we started the service in 2013, it was using a needle, essentially an acupuncture needle or a similar 27 gauge needle that we introduced, and it's called percutaneous tibial nerve stimulation or PTNS. Now, more recently, we've actually innovated and we've developed a new type of tibial nerve stimulation, along with collaborators across the world, which is called TTNS, transcutaneous tibial nerve stimulation. And as you can see, the difference here is essentially it's a patch that you apply. So if you have a TENS machine and you have it on the right type of settings, you could actually do this at home. And this is the beauty of TTNS is that it doesn't require you going into a hospital every week for 12 weeks to have the treatment, but rather you could have the treatment done at home. So you come into the hospital to be shown where to apply the patches and how to use the machine, essentially a TENS machine. But once you're set up, you could actually do it at home, either by yourself or with the help of a spouse or a carer. We move on to botulinum toxin, which has revolutionized the management of bladder problems in neurological disease. It is licensed for use in the United States for any neurological condition, whereas in Europe and the UK, it's specifically for MS and spinal cord injury, but we do use it for other neurological conditions as well. So it's injected by a urologist using a camera, which could be either a flexible cystoscope that you can see here or a rigid cystoscope. So in our service, we deliver it using a flexible cystoscope, which means the patient doesn't need to have a general anesthetic. They come in, the entire procedure is around 10 to 15 minutes. We inject into the bladder wall and out they go. And the effect lasts for 6 to 8 months, though the original studies showed up to 10 to 12 months and a very, very low discomfort score. Moving on about urinary retention. So we do explore whether intermittent self-catheterization is possible. So this essentially involves introducing a tube called a catheter, either by yourself or by a carer or a spouse to help empty the bladder. So we do need to identify the right sort of individuals, so individuals who are retaining urine, and assess their suitability. So we assess their truncal balance, their dexterity, their hands, their vision, their memory, their behavior, and their cognition. And if we feel that they're suitable, then there's a session of teaching. So it isn't just handing out a catheter and say, off you go, try it out. our nurses, and we expect in any service that the person is shown how to use the catheter, that they should be using it once when they're with the nurse so that they overcome it. And that teaching session will be followed up either by another teaching session, which is face to face, or by a phone call if we feel that the person has gotten a handle of what's going of what it's about. There is a huge market for catheters and different companies. It can be marketed as the size of a lipstick balm. I mean, it's that discreet. And sometimes you have catheters that have bags attached as well. Now, occasionally you may need to have an indwelling catheter needed, a discussion about this. So this is a catheter that doesn't go through the water pipe down below, but rather it's directly into the bladder. It stays in the bladder, I beg your pardon. So it's a bladder, so it's a catheter that's not removed, but it remains in the bladder. Either this can be left through the water pipe that we call the urethral indwelling catheter, or it could be introduced through the belly, and we call this below the belly button, called the suprapubic catheter. Now, for someone who needs an indwelling catheter for the short term, it makes sense to have a urethral indwelling catheter. But if we think it's for the long haul and that this individual may need a catheter for a long period of time, we prefer a suprapubic one, the one that you can see in the picture here that goes through the tummy. Now, the reason being is if you have a catheter going down, you can imagine how difficult it is to toilet. Also, you can imagine, particularly in a woman where the bowel sits close to the bladder, that there's a risk for infections if you have a catheter here, whereas the risk of infections is less here. Also, you can see that there's a balloon that goes in, but there's also a pipe that's keeping the water pipe open. So if you have this for years and years, what happens is that this pipe may permanently become stretched, in which case a person starts to leak urine along the sides of the catheter. Now, the medical term for this is bypassing, but we don't want this to happen. And this is why, if we feel that a catheter is needed for the long term, we would have a discussion with the person and their spouse and or their carer about a suprapubic catheter. And sometimes that discussion may go on for a few sessions, but we then, if we feel that it's appropriate and the individual feels that they'd like to proceed with it, we have our urologist who's able to insert this catheter in. Now, if there is an indwelling catheter, there are different types of bags that one attaches. And the bag that one uses in the day is called a leg bag, which is something that's discrete, attached to the leg using a Velcro strap. Whereas the one that one uses in the night is a night bag, which is a larger volume. So it allows the person to sleep through the night without the worry of having to empty their bladder. Now, we do encourage people to use a valve if they do have a bag attached so that it sort of replicates the normal physiology. The bladder fills, then empties, then fills, then empties. That happens with the bladder in health. Whereas if you have a bag that's connected to the catheter and it's just freely draining, then that physiology is lost. And so we would have a conversation about a valve. Sometimes it's not retention, but there's a problem with incontinence that we have to manage, in which case a catheter may not be required, in which case it's a conversation about different types of pads. There are different continence appliances that can be used, or even penile sheaths that we sometimes call as convenes that can be used as well. Now, I'd like to end about what we do, how we generalize this, because it's great. You've heard this, so and now you know about it. But what happens really at the grassroots levels? How do we make this happen at the centers where you see your doctors? So over the pandemic, so over a 4-year period, we put together a task force of urologists, neurologists, and physiatrists dedicated to developing guidelines for neurologists on how to manage the bladder and sexual problems. So guidelines are there for urologists, but not everyone is lucky enough to see a urologist and may not be lucky enough to see a urologist who understands your ataxia disorder. So with that felt need in mind, we put together some guidelines, and this has been published actually just 8 weeks ago, and it was between 3 societies, but you can see that we did have representation from North America. So Tamara Kaplan is a neurologist based at Harvard, who is actually a uroneurologist herself. and was actually quite heavily involved in this. But we did have from most of the continents, we had representation. Now, the recommendations are based on evidence, and we've put together recommendations for everything, all the different aspects of bladder management. And this is the actual guidelines that's been published. Now, if you scan this QR code, you will actually be able to access the guidelines free of cost. And you could also then send it on to your treating doctors as well. And so it's only been around 8 to 10 weeks old since it's been published, so people are just becoming aware of this guidelines. But I'm just giving you an example of what the algorithm looks like in these guidelines. So really, it's everything we've covered about, asking the patients the questions, or what to do if there's a urinary infection, when to test for urinary infection, when not to, what to do with the 3-day diary, blood tests for the prostate, for kidney functions, which one are they needed, measuring the post-word residual volume, catheterization, different medications for using for managing the bladder, and also your conservative measures. We also have this guideline also covers sexual symptoms and covers the what questions a neurologist should ask about sexual problems, about what blood tests may be needed, about covering other aspects of the neurology that can impact sexual performance, such as weakness and spasticity, but also the impact that the neurological diseases can have on intimacy in the relationship, such as changes in body image. These are all topics for another lecture, I'm afraid, but also about different treatments that are available. We've touched upon things such as vibrators and vacuum devices, really because we had patients on the committee who really felt strongly about these. So despite there being very low evidence, we still built in recommendations. Now, for the neurologists, we've also created a checklist for them to use to ask you which questions, so we make sure we don't miss any of the important questions for urinary and sexual symptoms. But I think the most useful bit was actually signposting when you need to be seen by a specialist, because not every person with a bladder problem needs to be seen by a specialist urologist. But there are certain conditions, certain situations where you should see a urologist for the urinary and sexual problems, and we've actually put together a list in this guidelines. I will also like to flag up guidelines in the ataxia disorders, such as these from Friedreich's ataxia, were updated 3 years ago, which also have a section on urinary and sexual problems, which I'm proud to say that I was involved in developing with my colleagues. So to recap, urinary bowel and sexual problems are common in the ataxia disorders. That there can be problems with holding the urine that we call overactive bladder symptoms, such as urgency, an increased daytime, nighttime frequency, and incontinence. There can be also problems with passing urine that we call voiding difficulties, and this includes that symptom of hesitancy, the poor and interrupted stream, and urinary retention. And we will always check to see if the bladder is emptying, and that several of these symptoms are treatable. That we can check fluid intake, there's medications, there's electrical stimulations, and there are now guidelines that can guide your treating team to assess and manage the urinary symptoms. So on that note, I have, I believe, a few minutes for questions. And so yes,
Thank you so much, Dr. Paniker. That was so helpful. The treatment strategies, super helpful. And I already see that there's some interest in getting that QR code again for the guidelines. So that is super helpful as well. So thank you so much for all that great information. And we've got several questions already. So getting right into it. Karen's asking, about 2 years ago, she developed a neurogenic bladder or urine retention. As a result, she is also prone to a lot of UTIs and has to do the self-catheterization 4 times a day. Do you recommend anything else for this? Also, I'm having delphamine, 10 milligrams for her other ataxia symptoms. Does it have any effect on her neurogenic bladder and urine retention?
I'm just looking at what delphamine is as we speak. That's why I'm on my phone. Um, I'm not sure what belfamine is actually, but yeah. So in the ataxia conditions, retention is there, and with a catheter, there's always a risk for infections. So what we do is the first step is that we will ask the nursing team to review the catheterization technique. We will then get an ultrasound scan to see if there's a stone or something sitting there that's causing the infections. Now, sometimes it might be helpful to then proceed with the test with the camera. So you saw the pictures of the cameras for injecting Botox, but the same camera can be used to have a look inside to see if there's some nidus for the infection. And time and again, we've picked up little stones. We've picked up a strand of hair that can go in during catheterization. And we found that by clearing the bladder of that, or maybe sludge sitting in the bladder, that their infections have improved. Now, when that doesn't help, then you can we try to avoid antibiotics, and so there are a couple of non-antibiotic options. So one of them is called D-mannose.
Oh,
um, if I can type that into the chat, I will. But D-mannose is something that's available over the counter in the United Kingdom, and I'm sure it's available in the United States as well. Derived from the bark of the birch tree, so it's a natural product which helps with preventing infections due to a specific bug called E. coli. Another
mhm.
option that you might want to consider is cranberry tablets. So not the cranberry juice that you get from the shops, but cranberry extract tablets. Now, if I wasn't able to figure out what this medication is, but if it is methenamine, that is another tablet that can be used to prevent infections. Now, if none of these work, that's when we start talking about preventative antibiotics. And what we would recommend is to actually cycle between antibiotics. So, for example, if there are three antibiotics the bugs are sensitive to, you take drug number one for 6 weeks, then you'd stop that and start the second drug, and then you stop that and try the third drug, and you rotate between. That's generally the strategy. But if you could tell me what this delphamine is, I can then answer the question, what exactly, whether that might help. Is that something used for ataxia, or?
It is a common medication for ataxia. I'd have to go back to our medications fact sheet to see all the symptoms that it can address. But it is a common medication that folks with ataxia are prescribed.
Thank you.
Absolutely. So an anonymous attendee is asking you if you recommend wearing pads or depends.
Yeah, so I think pads are quite helpful, but it very much depends on the context. What often happens in primary care is that it's almost like a reflex, oh, you got incontinent, have pads, and it's pads for the rest of your life. And I think that's something that we cannot encourage, because there hasn't been an attempt to try to find out why the person is incontinent, or trying all these wonderful treatments that are available for the incontinence. So for someone at that stage, it's a definite no. But if it's someone who does have incontinence, pads may actually allow them to go out and to do things they'd like to do. It also gives them that sort of protection, or that security when they go, that they won't have an incontinent episodes.
That's great. And there's a couple of comments in the chat thanking you for this wonderful presentation. Also, for interest in that slide with the QR code to the guidelines, would you be able to share that one
Sure.
with our folks again? Awesome.
Once you ask the
That was
question,
so helpful.
I'll share the slides. Yeah, but do carry on with the questions.
Absolutely. So we got a few on Botox, and I know that you touched on this. This anonymous attendee is asking, they have had Botox treatment twice now, and when should they schedule their third treatment? Should they wait until the Botox is pretty much gone from their body?
So, ideally, yes, is that when you feel that your urinary symptoms are returning, and that's when you would then book yourself in for the next Botox treatment. But what we find, particularly in the United Kingdom and the NHS, the way the healthcare system is that often at that point in time, there's a very long waiting list. So more and more, the urology practice in the UK, what we do is we have someone who comes in today, we'll give them a fixed appointment for 6 months' time. So we know that at least they can come back into the service at that period of time. But if you are in a service where actually the appointments are easy to get, then yes, when the symptoms wear off, that's the time you need to come in, plan your next Botox.
Gotcha. And then Peter is asking also about Botox. What are the pros and cons?
Oh yeah, yes. So Botox, the pros. I mean, it helps with the urgency, helps with the frequency. And I would say amongst all the treatment options you've heard today, it's probably the most effective in terms of these symptoms. So super effective. Very few side effects like you heard about, like a dry mouth, memory problems, and all. Now,
Hmm.
what it is that Botox, wherever injected, relaxes a muscle. So if you inject Botox for spasticity in your leg, you're essentially relaxing a muscle. If you're injecting it for a dystonia in your arm or a leg, once again, you're relaxing that muscle. So here, what we're doing is we're relaxing the bladder muscle. Now, if the bladder muscle is relaxed, it's unable to empty itself. And so there's a risk for developing urinary retention. So this is the one thing that we tell individuals when we counsel an individual about Botox is that there is a risk for developing urinary retention, and the figure is around 30%. Means 1 in 3 individuals may develop urinary retention. And so before they have their first Botox treatment, they are taught intermittent self-catheterization, or a carer is taught ISC, or we elect that they go on to have an indwelling catheter. Now, what the good thing is that everything is temporary for Botox. There's no permanent side effects or effects, which means that the person has retention that reliably, after around 2 to 3 months, the retention begins to reduce, and probably around 6 months, they'll not be retaining anymore.
Well, that's very helpful. It looks like we have time for maybe one more question. And so Ernest says he wakes up at night to urinate and can't go back to sleep. Do you think it's spinocerebellar ataxia related?
Possibly it could be. That's a common symptom that individuals with spinocerebellar ataxia report. But do remember that getting up at night to pee is a very, very common symptom in the general population. And so it could be from drinking too much before going to bed. It could be from having an enlarged prostate, or it could be having a medical condition such as heart failure. So I think before we conclude that it's due to the ataxia, there needs to be a checklist of things to exclude.
Exactly. I would agree. Well, that's all we have time for today. Thank you so much, Dr. Paniker. This was so informative. We'll definitely want to have you back to talk with us again if you're open to that.
But I'd love to. Thank you very much for having me.
It was a pleasure. And thank you all for joining us. This webinar is being recorded. So a recording will be available in about a week on NAF's YouTube channel and on NAF's website. And thank you again, everyone, for joining us. Thank you again, Dr. Paniker. Take care, everyone. Till next time.
Thank you very much, guys. Thank you. Have a lovely
Thank
day.
you.